The examination of the knee is done, as always, with inspection that's followed by palpation and range of motion. With inspection, one looks at the dorsal, medial, and lateral aspects of the knee for swelling on either the medial aspects in the medial recess inferior to the patella or in the lateral recess inferior to the suprapatellar pouch. The palpation of the knee is done by palpating either along the lateral joint line as well as along the lateral collateral ligaments, which begin here on the distal femur and insert inferior to the joint on the tibia. Palpation and tenderness along that area is suggestive of a lateral collateral process such as a tear. The same may be repeated on the medial aspect of the joint, where one palpates along the medial joint line. The medial collateral ligament runs along the medial aspect of the joint and can also be a site of tenderness. Or the tendon that runs from the tibial tuberosity, which is frequently involved in younger children that are undergoing growth spurts. And tenderness over this site is also an overuse syndrome. Patients that come in and tell you that have pain playing basketball or playing sports that localizes to this area often have a tendinitis that can be reproduced by palpation at this site. Patients with tenderness over the anterior tuberosity of the tibia at the site of the tendon insertion is called Osgood-Schlatter's disease, and a site that usually happens in young men or young women undergoing rapid growth spurts. The clinically important structures around the knee are bursa sacs that can exist in an infrapatellar, prepatellar, or suprapatellar region along the femoral tendon that inserts on the patella and the patellar tendon that inserts on the tibia. In addition, there is an additional bursa on the medial tibial plateau that is called the answering bursa. This is the bursa that allows smooth movement of the hamstring muscle that's coming posteriorly up to the front and inserts on the tendon. The name of the hamstring, the muscle that does this, is a semitendinosus muscle. The remainder of the knee exam is establishing the presence or absence of fluid. Now clearly that's going to be evident when one examines the knee, just to see if there's any swelling, particularly in the medial recess where it's most easily visualized. In obese people this can be somewhat difficult, but what one tries to do is that unless there's a frank effusion, which one feels by palpating along just inferior to the patella, along the joint line of the patellofemoral joint, is one takes one's hand and milks fluid from the suprapatellar pouch, which is continuous with the joint line, and also pushes laterally, and then palpates medially to see if there's any fluid that can be transduced or distracted into the space. The movement of the knee is that like the elbow, is a hinge joint. The knee should have nearly full extension, or should have full extension. It doesn't usually have to have hyperextension. And like the elbow, small degrees of flexion contracture can be present with the patient being completely unaware. One should then be able to flex the knee fully and bring at least to 135 or 150 degrees. And this represents normal motion of the knee, or actually normal motion of the tibiofemoral joint. The motion of the patella on the femur, the so-called patellofemoral joint, can be also evaluated in this way. One looks at the patella while one is flexing it and extending it to make sure that the patella rides in a central location. Patients can describe pain from the patellofemoral joint because of an overdeveloped quadriceps muscle resulting in lateral distraction or lateral excursion of the patella when they are flexing or extending the knee. This can be elicited or reproduced, and this is often also called chondromalacia due to the wear of the cartilage underneath the patella, by putting one's thumb on the patella when the knee is in flexion and then flexing it and seeing if crepitance, that is a bone-on-bone sound, or pain can be reproduced with either flexion or extension.